Forward Media. This is Healthcare Musings. I'm your host, Dr. Hassaballa. Welcome to Healthcare Musings, everybody. Happy to have you with me. So I was there in person when the 2026 sepsis guidelines were released by the Society of Critical Care Medicine at the Congress. Now, I had to speak at the same time, so I didn't get a chance to attend the presentation in person, but definitely a lot of cool things that I wanted to talk about this week on the podcast. So there were a total of 129 statements. 17 of them were strong recommendations. 81 were conditional recommendations. They had 19 good practice statements and 11 statements that had insufficient evidence. And compared to the last time, which was in 2021, there were 46 brand new statements. 38 were revisited. 44 were carried over unchanged from the last time. And so these are the things that I thought were most important as a clinician, as a physician leader, and as a physician advisor. The first and foremost is, what is sepsis? So this is what they said, quote, sepsis is a clinical diagnosis and should not be ruled in or ruled out using a single biomarker or diagnostic test, unquote. Right there. No mention of SOFA. No mention of QSOFA. In fact, they even went through a bunch of early warning systems and screening systems, and they said that you should use SIRS or NEWS or MUSE over QSOFA, right? And the point is, this is a clinical diagnosis. There's no one thing or a group of things that rules in or rules out sepsis, okay? And that flies right in the face of insurance companies and their third-party auditors when they try to say, oh, they didn't have a SOFA score, so they didn't have sepsis. Nope. Just as the guidelines say, it is a clinical diagnosis, and therefore only clinicians are qualified to make the make the diagnosis. So there you go. And I'm going to be using this argument, and I'm going to be quoting this directly ad infinitum when I continue to appeal these sepsis DRG denials. The next thing, this is another vindication of Dr. Hassabolus with respect to fluids. So I'm going to quote, for adults with sepsis-induced hyperperfusion or septic shock, we suggest administering at least 30 ml per kilo of IV crystalloid in the first 3 hours. This was a conditional recommendation with low certainty evidence. And fluids should come before vasopressors. Quote, for adults with sepsis-induced hypotension, we suggest initial IV crystalloid bolus resuscitation followed by vasopressor support if hypotension persists. This was a conditional recommendation with very low certainty evidence. There you go. You have to be aggressive with fluids early, 30 ml per kilo. And what if they have CHF? What if they have renal failure? They addressed it in the guidelines. Quote, a retrospective analysis of adults presenting to an emergency department with sepsis or septic shock showed that failure to receive 30 ml per kilo of crystalloid fluid therapy within 3 hours of sepsis onset was associated with increased odds of in-hospital mortality, delayed resolution of hypotension, and increased ICU length of stay, including in patients with end-stage kidney disease and heart failure, unquote. There you go. Dr. Hassabolus has been vindicated. Everyone's so worried about volume overload in people with CHF. It's one thing if they come in volume overloaded, if they have end-stage renal disease or CHF. A lot of times they're not. They're volume depleted, even if they have an ejection fraction of 10%. They come in, they've been vomiting, they've been diarrhea, they've been not been eating, they've bad appetites, they've been febrile and have insensible water losses. All of that, they come in volume depleted. You got to resuscitate them, even if they have heart failure, even if they have end-stage renal disease. And then they didn't recommend one over the other with respect to a liberal or a restrictive fluid strategy. Quote, for adults with sepsis or septic shock who have already received fluid resuscitation with 30 ml per kilo and have persistent hypoperfusion, we suggest using either a liberal or a restrictive fluid strategy, a resuscitation strategy rather, based on individual patient and health system factors. This was a conditional recommendation with low certainty evidence. Okay. And they mentioned further, there was, quote, there was wide variability in the protocols used and the volume of fluids received in the liberal versus restrictive arms across trials. Patient and health system factors to be considered include patients' current clinical conditions and chronic illnesses, e.g. heart failure, and the availability of monitored beds, i.e. if a restrictive approach necessitates vasopressor use, unquote. Okay? So, yeah, I mean, they don't recommend one over the other. So being aggressive is completely acceptable. And everyone knows I am in the aggressive camp. Now, this is not, fluids ad infinitum. If they are not working, okay, if they're not fluid responsive, then you can go straight to vasopressors. And they mentioned this, quote, in patients with unstable septic shock, immediate concurrent administration of vasopressors together with an IV crystalloid fluid may be warranted on a case-by-case basis. Presence of unstable shock should be determined by physical examination. Suggestive clinical features of unstable shock include severely reduced blood pressure, mottled skin, ashen appearance, cyanosis / decreased oxygen saturation, tachycardia, and altered mentation. Unquote. So again, you don't have to wait until you give 30 ml per kilo. And is it full body weight or ideal body weight? They talk about both, right? Because of someone who's more, I'm not afraid. Okay, someone's who has a BMI of 60, I'm not afraid of giving 5-6 liters of fluid, but some are. And so maybe in that case, you can use ideal body weight. Again, I'm not worried about it. You have to give fluids and you have to be aggressive with them. And so once they're resuscitated, you can always take the fluid out. You can always dialyze them, or you can always diurese them. And the guidelines mention this, quote, for adults with septic shock after the acute resuscitation phase, we suggest using active fluid removal. Okay, this is a conditional recommendation with very low certainty evidence. And in the remark, they say, quote, active fluid removal refers to diuretics, and if diuretics are insufficient, ultrafiltration or extracorporeal fluid removal, unquote. Okay, so you can always take it out later. But, someone who's dry coming in, even if they have heart failure and you give them a cup of coffee and start vasopressors, you could make them worse. You can hurt their organ systems worse. You got to be aggressive with fluids early. Dr. Hassabolus has been vindicated once again. The other thing that I found was interesting, quote, for adults with septic shock 65 years old or older, we suggest an initial MAP range, MAP meaning mean arterial pressure, MAP range of 60 to 65 over higher ranges. This was a conditional recommendation with low certainty evidence, unquote. So this was interesting. Like there seems to be some signals in the literature that perhaps MAP of 65 may be detrimental, and so they talk to people with 65 or older. Maybe you can target a mean of 60 rather than 65, or a mean of 62 or a 63. This is good for me to know, and it's also good for me to know that for most people who are younger than 65, we should still be targeting a mean of 65. That's very good for me to remember. Peripheral vasopressors, here is what they say, quote, in adults with septic shock, we suggest starting vasopressors peripherally to restore mean arterial pressure rather than delaying initiation until central venous access is secured. This was a conditional recommendation with very low certainty evidence, unquote. So that's good. It takes time to put a central line. It takes time, and it's associated with complications and pain. And so if you can just have a good IV, you can start it peripherally and start resuscitating and treating the hypertension right away rather than waiting for a central line to replace. That's awesome. That's what we've been doing. And if they start needing more vasopressors, or you're not sure about the IVs, then you put central lines. But we shouldn't delay treatment until a central line is established, and that's actually really good to know. Same thing with non-invasive blood pressure monitoring. This is what they say, quote, for adults with septic shock, we suggest using either invasive or non-invasive blood pressure monitoring, and this was a conditional recommendation, very low certainty evidence. And in the remark, it says, quote, invasive blood pressure monitoring is advised in patients with shock who require intermediate to high dose vasopressors, escalating doses of vasopressor or multiple vasopressors, are receiving frequent arterial blood sampling, or have non-invasive blood pressure measurements which are inconsistent on repeated assessments, unquote. That makes sense, right? But it's not now, the mantra that you have to have an arterial line every single time. You don't. They actually, if you trust your cuff pressures, you can use them, and this is great. And I've been doing this and peripheral vasopressors in my practice, and it's good now to see that the guidelines support it. But at the bottom line, sepsis is a clinical diagnosis, nothing to do with SOFA or QSOFA, and we should use that again and again and again and again when we argue with insurance companies about what is sepsis and what is not sepsis. It's a clinical diagnosis that needs to be made by clinicians, period. There's also uh, we should use we should be aggressive with fluids early. We should not delay or under resuscitate. And if in the worst case, we can always take it out later. And we can use peripheral vasopressors and non-invasive blood pressure monitoring. So really cool stuff. Maybe later we'll go over the strong recommendations. Again, a lot of the evidence behind this is on low certainty. And maybe another episode we'll go over the strong recommendations and comment on that. But just Dr. Hassabolus has been vindicated once again. And this was kind of cool. And it was kind of cool that I was there in person. Anyway, guys, thanks so much for your time and attention. And we'll see you next time on Healthcare Musings. Thank you for listening. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.